Good evening, everybody. Welcome to this BTOG World Lung and ESMO 2024 update. My name is Tom Newsom-Davis. I am a medical oncologist at Chelsea and Westminster Hospital, and delighted to be chairing today's meeting, which, as you can see, has registered with the RCP for your CPD credits. First of all, a little bit about the good people of BTOG. I'm sure you are all BTOG lovers, and I'm sure you are all very familiar with being a member of BTOG, and I'm sure this webinar will go smoothly. But if you need anything regarding catch-up of this or accessing the virtual platform or anything about your membership, do please contact Gina and Dawn, with lovely pictures there, on the email or website, as you can see. We love interaction, and really the best bit of all these things are your questions. So through the miracles of technology, you can indeed ask us questions, only if it's live. Clearly, if you're watching on catch up, that you can't be asking questions, but you can submit those questions through the control panel on the right hand side of your screen. They appear as if by magic on my screen to my right, and I can pass them on to our excellent panel. We'll send you an email, give you feedback, you get your certificate of attendance, and as mentioned, this will be RCP approved in the imminent future. So what have we got lined up for you? Well, we've got three excellent speakers. We've got Professor Martin Forster, who is a medical oncologist at UCL Hospitals in London. We have Yvonne Summers, also medical oncologist at the Christie in Manchester. And finally, we have Meenali Chitnis, who is a medical oncologist at Oxford University Hospitals. And as you've noticed from our agenda in front of you, we have put together World Lung and ESMO in one happy sandwich. And the reason for that is that World Lung and ESMO were but 1 week apart, the beginning of September, which is remarkably poor organisation by the two respective bodies, because it obviously meant that not everyone could go to all of them. But it does give us the advantage of the fact that actually we can present all the data to you here. So we're going to start off with Martin, who's going to tell us about the World Lung updates, and then Meenali and Yvonne have split ESMO into metastatic disease and the early and locally advanced. We're going to go straight through those presentations, and then any questions you have for us, we're going to discuss at the end, and we'll be done and dusted at 7:30, if not a little bit before. I just remind people that you can catch up on this presentation through the BTOG website. We usually have around 100 live viewers and up to 500 to 600 even more catch-ups as well. So it's a very popular way of doing it. And you can also hear catch-up of the audio of this as part of our podcast as well. So enough from me. I will pass you on to my colleague and friend, Martin, who's going to tell us about updates from World Lung 2024. Thank you very much, Martin.
Thanks, Tom, and thanks to the organising committee to give me the chance to give an update from World Lung. I don't want to start off feeling too negative, but there was not very many really big practice-changing studies presented at World Lung, but as always, it's a great opportunity to reflect on the data that we have and how it's being interpreted and used across the world. My name's Martin Forster. I'm a medical oncologist, as Tom mentioned, based at UCL down here in London. And these are my disclosures. So similar to how Tom's outlined the ESMO updates to be done, I'm going to condense and present the data from World Lung by early, locally advanced, and then advanced stage, with a tiny bit of small cell at the end if we have a chance. These slides will be available for you. So some of these I'll go through reasonably quickly, just so there's information for your perusal later on without dwelling on it too much. And hopefully we can focus on any clarities in the questions later. So in early stage disease, this is obviously an area of huge discussion at the moment, debate around the management of patients with operable disease. Actually, there was no really new data presented from new randomized trials at World Lung. However, we know that there are quite a lot of data available in the context of adjuvant chemotherapy with or without immunotherapy, with or without targeted therapies such as osimertinib, and now the use of neoadjuvant treatment. And although it's not available in the UK yet, in other parts of the world, the use of perioperative treatment using both neoadjuvant and adjuvant treatment. These approaches have not been compared in randomized trials, but we saw some really interesting data from two of the BMS studies with nivolumab, So the Checkmate 816 study looked at 3 cycles of neoadjuvant chemotherapy with nivolumab. This has been presented a few years ago and has led to the approval, including our access here in the UK, based on an event-free survival benefit with a hazard ratio of 0.63. A second study, the Checkmate 77 T, was a similar sort of design initially. It had up to 4 cycles of neoadjuvant treatment, again with chemo plus nivolumab, and then those patients went on to having adjuvant nivolumab thereafter. So that was a perioperative approach. So as I say, there's no randomized data, but what was presented at World Lung was this study looking at those 2 studies side by side, but actually breaking it down into patient level data analyses to try and learn about the best approach. Essentially, what this evolved doing is looking at patient level data and then looking at them in an unweighted, and then and also trying to do some manipulation of the data to try and match it as possible. And here you can see the unweighted data. So this is, of course, raw, so it's not exactly matched, but not too dissimilar. And both studies had a similar pathological complete response rate of around 25%. You can see here there's slight differences in stage of disease between the 2 studies and in the Asian racial mix. If you look at the looking at the 2 studies when they put the data together, you can see here overall with the weighted analysis and the unweighted analysis, it turns out that there is an improvement in the event-free survival with the perioperative approach. Interestingly, when you look at those patients who got a pathological complete response, that was less marked. And really the main benefit was driven by those patients who didn't have pathological complete response to the neoadjuvant component, perhaps quite as intuitively you might imagine. But less intuitive, I think, is the fact that the patients who had PD-L1 negative disease seemed to gain more benefit from that adjuvant. And the adjuvant approach, remember, was just single agent nivolumab, but that seemed to be the patient population who did best. Perhaps the underlying population with the neoadjuvant approach doing slightly less well, but in particular, but again, this is across the trial comparisons. So if we look at tolerability and toxicity, you can imagine the preoperative component was very much the same. And actually the tolerability, although there was more adverse events in the adjuvant component, that would be not surprised. They were on treatment for much longer if they were treatment related, but overall it was pretty similar tolerability. So in summary, this is data that's not quite ready for us to change practice at the moment because we don't have access to 77T or any perioperative approaches at the moment, but it does guide us by showing that there did seem to be those patients who went on to have adjuvant nivolumab, at least 1 dose of that, seemed to have, unrelated to stage, benefit with the perioperative approach, albeit the fact that was particularly noted in those patients who were PD-L1 negative and those who did not achieve a path CR to the neoadjuvant approach. Seemed to be manageable toxicity-wise. And I just throw in there that the question I wonder about is whether or not just continuing with the same single agent PD-1 or PD-L1 is enough for those patients who don't get path CR, but maybe that's something we can discuss later. When it comes to locally advanced non-small cell lung cancer, again, there was no, I don't think, practice-changing studies that are going to be particularly relevant here to the UK. This is not a study I think we need to dwell on too much, but this is the Polestar study I'm just going to throw out there for your information, which is looking very much in the same approach as the LAURA study, which is being evaluated, you may well be aware, looking at the role of consolidation osimertinib in those patients who've completed chemoradiotherapy for inoperable stage 3 disease. And this study, the Polestar study, was looking at another 3rd generation TKI called omalotinib, and looking in a similar way to patients who've completed chemoradiotherapy with harboring a classical EGFR mutation and being randomized to having treatment with TKI until progression, so for evermore, potentially, versus a placebo with crossover being allowed. And here you can just see that there's a very clear separation in the progression-free survival curves within this study, similar to similar benefit, at least not similar in numerically necessarily, but benefit confirming, I think, like Laura, the approach of targeting using targeted therapy for these patients post chemoradiotherapy. So again, to discuss, I think interestingly, how this may be interpreted, not with necessarily this drug, but with osimertinib, if that gets approved, how we're going to select these patients and do this. And also, I think the spin-on effects about how that may influence other rarer oncogenic driven cancers in this consolidation space. Coming to advanced non-small cell lung cancer, and thinking initially of targeted therapies. I'm not going to dwell on these. I'm just really putting these slides for you together because there were no practice-changing studies, but there were 4 studies at World Lung, which I think showed some interesting information with new drugs or new combination of drugs. This first one, the Flowers study was looking at patients who had both EGFR classical mutations and de novo MET aberrations. So this is at diagnosis. We know that MET signaling is important in EGFR TKI resistance and osimertinib resistance in particular, from other data in the first and second line settings. So this is a study looking at giving the 2 drugs together upfront for this population. It's quite rare, only in a few percentages of patients with EGFR activating classical mutations. But you can see in the data here, which you can have a look at, that there was a significant, well, say an improvement in overall response rate and duration of that response by using the combination. This was associated with more toxicity, but was manageable. The other 3 studies I've just highlighted here are 3 newer drugs. So furmonertinib is a drug which was developed in China, which is a drug targeting exon 20 mutations, either in EGFR or HER2, but also has activity in EGFR classical mutations. It's approved in China for that, and it's FDA approved for exon 20 EGFR mutations. And this is a study looking at a different cohort with these mutations. So these are an interesting approach at looking at EGFR mutations, those less common ones, but identifying them by the structural change that they have, which kind of makes sense if you're thinking about novel drugs and how they may affect binding, is how the impact the mutation may have on structure. And this classifies some of those more uncommon mutations into the PAC mutation classification. And this was a study looking at 2 different doses of Firmo within that setting. And you can see here a significant response of over 80%. These mutations are not generally sensitive to most first, second, or third generation TKIs. So this is quite an impressive response rate. And the vast majority of these patients remain on study in this immature data set. So durability of response so far looks quite promising. And then 2 studies looking at new drugs targeting HER2 mutant disease, so patients with HER2 exon 20 mutations. And we saw a drug in the SOHO-1 study from Bayer, which was both of these are cohort expansions in the phase 1/2 studies. So not data I think is going to be practice changing for us, but just a change of sort of potential, because in the past we've known that these TKIs have not been so promising in HER2 mutations or HER2 driven disease in lung cancer compared to other cancers. And of course there is activity with the ADCs in this situation, but both of these drugs showing a significant activity, including intracranial activity in these very early phase studies. So just drugs to watch, and an idea that we may be able to move into the TKI zone for these HER2 driven diseases as well. When it comes to immunotherapy, we have one study I think it's worth us just dwelling on for a few moments, which is the Harmony-2 study. So this was a randomized phase 3 trial looking at patients with PD-L1 positive non-small cell lung cancer, so those with PD-L1 high and low, so greater than 1% by TPS scoring. And it randomized those patients to pembrolizumab as the perceived standard of care, and a bispecific drug, ivonescimab, which is a difficult name, which is a bispecific targeting both PD-1 but also VEGF. So we've seen a number of these drugs coming through, and this is a study that was run uniquely in China, randomizing between the 2 drugs in a big phase 3 study. We can see here that the characteristics were fairly balanced. I just highlight here that there was about half the population had PD-L1 high and half PD-L1 low disease. And we can see here what, for the point of view of progression-free survival, really quite a significant increase from PFS with pembrolizumab in this mixed population of around a bit less than 6 months, which is consistent to what we've seen in Keynote 42, for example, which looked at the same population, nearly doubled to over 11 months in the with the novel agent. So suggestion here within this study of activity. Of course, interestingly, this was seen in both the PD-L1 high and low. Of course, that's an area we're particularly interested in because our standard of care wouldn't be to give single agent pembro to PD-L1 low disease, but you see sort of similar levels of benefit in both populations, and it was independent of histology. Not surprisingly, there was more toxicity with the novel agent, particularly with the toxicity driven by those VEGF signaling. So the renal effects, proteinuria, blood pressure, and some laboratory abnormalities. So essentially, toxicity manageable and as would be predicted. So I think this is something that, again, whether this will change practice for us, I think is something to consider. There's a few factors to this. This was a all PD-L1 expressing tumor population, so not typical where we'd use pembro as a standard of care. It was a study delivered purely in China, so the potential racial differences there as well. And the OS data are not mature, but still, I think quite provocative data for us. And interestingly, the drugs were pretty well tolerated, including those who were getting with squamous cell cancers. In the antibody drug conjugate space, we saw, I think, again, I've paired these studies together, which I think are quite interesting to us. I don't think they're going to be practice changing for us, but they may have a global impact. And this is now looking at the TROPION-Lung01 study. So this is a study looking at patients who are pre-treated with chemotherapy and immunotherapy at least, and for those who had actionable genomic alterations had also exhausted targeted therapy options. So in other words, a second line plus study randomized between docetaxel as the standard of care with Dato-DXd, which is the TROP2 targeted ADC developed by Daiichi Sankyo and being co-developed now with AstraZeneca. So this is an antibody drug conjugate, so the payload is attached and delivered into the tumor, and we'll touch upon that again in a few moments. Paired primary endpoints with progression-free survival and overall survival, and we've seen these data before. So this is the progression-free survival, which was presented before, and it was a little bit disappointing, I think. We can perhaps discuss this later. They had a different toxicity profile, not surprisingly, but you can see in the intent to treat population, the primary endpoint of PFS, which was previously presented, showed less than a month's improvement, although that was statistically significant, and slightly more improvement in the non-squamous population, but still only less than 2 months improvement in progression-free survival. So some signal of activity, a little bit disappointing. This is being evaluated by the FDA as to a decision about whether this is adequate to drive a license. And this is in part because the toxicity, although different for these ADCs, and certainly they're not a total non-toxic regimen, in general were viewed as being slightly less intense than docetaxel. And we all know that we're all looking for replacements for docetaxel. So the advocates for this feel that this is a slightly better tolerated treatment with marginally better efficacy. So what we saw at World Lung was the data from the overall survival, the second co-primary endpoint, which disappointingly showed no survival benefit. So I think this will not be a treatment that will be changing practice here in the UK. As I say, in the US, apparently they're still considering it based on the PFS data. Now, what was interestingly, we saw a second presentation from the same study, and this is essentially looking at a better biomarker. So in the development of this molecule, and in fact, the TROP2 ADCs as a class, there has up until now, there's not been a good predictive biomarker. So looking at TROP2 surface expression with immunohistochemistry, for example, does not predict for activity. So what this subgroup looked at trying to look at a different way of looking at TROP2 expression. This is kind of complicated, but I think the simple way of looking at it is rather than looking at the expression on the membrane, this is looking at the expression of the membrane relative to whole cell expression. So the expression of the membrane and the expression within the cytoplasm. So the total cell TROP2 level as a ratio, so membrane to cell TROP2. With the rationale being that the transport of the ADC, which needs to be internalized to release its payload, perhaps may relate to its activity. So this is done through a novel approach looking at quantitative continuous scoring to develop this normalized membrane ratio from within this TROPION-Lung1 study. And so that you can imagine, not all patients had adequate tissue, so they had what they called their BEP, so their biomarker evaluable population, which was those patients where they did have enough tissue to do this. And perhaps not surprisingly, there was this was not equally distributed amongst the patients, particularly when it came to histology, with more expression of this ratio being positive in non-squamous cancers than in squamous cancers. What was quite interesting, though, is when they looked at this biomarker population, there was a more clearer separation of the curves when it came to PFS for those patients who received the Dato-DXd, so the novel agent, the TROP2 ADC, and had a positive test with this QCS NMR. So if that ratio was positive, that predicted better for benefit for the ADC. So I think this is really interesting. The concept to me of having these targeted chemotherapies where the target doesn't correlate response is something that's always set quite uncomfortable with me, albeit the fact there's lots of discussions we can have about that later if we want to, but conceptually it doesn't really fit for me. And so the idea that we can have perhaps better ways of understanding this biologically, of course, needs further validation, but is very interesting and may help our utility of these drugs going forwards. So to finish off, I'm just going to briefly touch upon small cell lung cancer. There was a number of approaches we saw presented in small cell lung cancer. We saw a number of what I think is quite exciting ADCs, so further antibody drug conjugates being looked at in small cell with some quite interesting data. These were non-practice changing studies so far, really just single arm studies, but still TROP2 being one of those, and other targets with ADC looking like they may have some activity in small cell post chemotherapy. So exciting that there are new drugs coming through. But the one I want to just highlight for the last couple of minutes was the tarlatamab study. So this is the DLL3 bispecific T-cell engaging therapy. So you may well have heard about this over the last 12 months or so. This is a bispecific therapy which binds the tumor cell through the DLL3, but then binds the immune cells through CD3. So this is not binding two tumor proteins, but binding one tumor protein and an immune cell, the T cell, through the CD3, and in doing so, activating the immune cell. This is really exciting treatment in hematological malignancies, and Tala has been showing some really interesting data in small cell, and this was an update of that data from a now this was the early study, which is randomizing between two different doses of tarlatamab, then expanding in the lower dose, which was felt to be the right dose to take forwards. This is a study that has been recruiting to in the UK, and it's exciting because, as you can see here, it has an objective response rate in second line or third line, in fact, but post chemo small cell lung cancer, so a population where we're in desperate need of more treatment, a response rate of around about 40%. So that's obviously very exciting, and that has been getting at least as good over time. And what's particularly interesting as we see these updated extended follow-up data is the durability of that response. So they have a quick time to response, essentially when you first look, and the median duration of response is extending out to nearly 10 months. So in relapse small cell, that's really quite outstanding. And I think these treatments are going to be evaluated very soon. They are theoretically available now in the UK through a compassionate use scheme in centres which are able to set that up. But there's something which will be coming forward. We see that sustained benefit in here now in that tail of the curve, which in small cell is really remarkable. Looking at survival, progression-free and overall survival, with a median overall survival of over a year for relapse small cell. So really incredible data. So this is very, very exciting. Of course, this is a different class of drug which has different toxicities. We may want to discuss the feasibility and the training that we're going to need to be able to deliver this routinely across the UK, because these are drugs that can induce an immune response much more profoundly than PD-1, certainly that we're used to managing in lung cancer. And although there's experience with this in hematological malignancies, this is something we need to learn within oncology, with things such as CRS and other acute toxicities coming in. as being something we need to learn and train our trainees and our nurses to manage. But very exciting data. It's coming to the UK. I'm sure will be a proof for us and will be something for us in the future. And thank you very much.
Martin, thank you very much. And well done for keeping to time. I threatened Martin with all sorts of dire consequences if he overran. That was a superb overview. And I think you're right, which is, excuse me, there is perhaps no groundbreaking plenary session piece of data is going to change what we do today, but there's a lot in there that I think will be influencing what we do in the future. So I will remind people about asking questions. Do that through the portal. I've had a couple through on my right here. So without further ado, we will move on to Meenali Chitnis, who is going to very kindly update us from ESMO about the metastatic aspects of data presented there. Meenali, thank you very much for joining us. And just to remind people, this is a huge ask that we impose on people. Conferences are busy times, everyone's running around. You get back to work, desperately trying to sort out your clinical work, and you get an email from me saying, would you mind doing the BTOG webinar? So I'm enormously grateful that they've taken the time out to do this. Meenali, the floor is yours regarding metastatic non-small cell lung cancer.
Thanks, Tom, and thanks for the opportunity to present today. So these are my disclosures. So what I hope to cover in the next 20 minutes or so is trials that were presented at ESMO in the metastatic non-small cell lung carcinoma space. I'm going to focus on 2 immunotherapy combinations first line, and also go to the oncogene addicted space and look at some of the emerging treatments in the EGFR, ALK, and ROS1 arena. So going straight into the first trial. This is the Galaxy's Lung 201 trial, which is a trial looking at the combination of dostarlimab and belrestotug, which is an anti-TIGIT antibody, in patients with metastatic lung cancer previously untreated and a high PD-L1. So dostarlimab is an anti-PD-1 antibody. It's got comparable clinical activity to pembrolizumab, which we've seen before in the PERLA trial. And TIGIT is an inhibitory receptor which contributes to suppression of the immune system. So very simplistically, blocking TIGIT with an anti-TIGIT antibody enhances the immune system in a number of ways, increasing CD8 proliferating cells and suppressing immunosuppressive Treg cells. So now looking at this trial, these were, as we said previously, untreated patients with a high PD-L1, and they were randomized to either getting dostarlimab alone or getting it in combination with 3 different doses of belrestotug, 100, 400 milligrams, and 1,000 milligrams. The primary endpoint here was objective response rates, and it was a relatively small phase 2 study with 124 patients at the evaluable at the interim analysis. Looking at the baseline demographics, essentially comparable, other than the fact that there were slightly better performance status patients in the combination groups with the belrestotug. And looking at the primary efficacy endpoint, which was the objective response rate, you can see here that there's an improvement with the combination arm, regardless of the dose of belrestotug used. So dostarlimab, you're seeing rates of 37.5% and going up to 63, 65, and then 76% objective response rates in the highest dose arm. And these responses were deep responses. So you can see in the waterfall plots here that you've got the PRs in green, and you can see quite a few of those suggesting good responses to the treatment, but not without toxicity. So you can also see here that the toxicity profile of the combination arm is more than with dostarlimab alone. Serious treatment-related side effects increasing from a baseline of 9% upwards of 25 to 37%, and discontinuation rates also going up in the combination arm with belrestotug, the most being in the highest dose group of 1,000 milligrams. Most of these treatment-related events were skin and subcutaneous tissue disorders, which the investigators said were very manageable with oral or topical steroids, and we're quite used to some of these immune-mediated toxicities, including the pruritus, rash, and hypothyroidism. But you can also see that, particularly in the highest dose arm, there were some grade 3 toxicities, including immune-mediated pneumonitis and myocarditis as well. So in conclusion, meaningful overall response rate seen in this combination of dostarlimab and belrestotug, but higher adverse events as well. We need additional follow-up from this trial, but there's already recruitment going to the Galaxy's Lung 301. This is a phase 3 study now where they've chosen the 400 milligrams, so the middle dose of the belrestotug going forward in combination with dostarlimab, and they're going to compare it with standard of care in the PDL high group pembrolizumab. So thoughts on this is we do need that phase 3 data. So we do need more efficacious combinations to improve on the response rates we currently have to first-line treatments. And there's definitely a rationale for combining TIGIT antibodies with PD-1 agents. But we also know that despite promising phase 2 data, sometimes a phase 3 data is negative, as we've just seen in another TIGIT antibody, tiragolumab, which was combined with atezolizumab in the Skyscraper-1 trial, which did not meet its co-primary endpoint of progression-free survival, despite the promising data. So if you look at our standard of care, which is KEYNOTE-024, as one of them, we see response rates of 46%, median PFS of 7.7 months. So you're really looking to try and improve on that with any treatment that might replace our current standard of care, and ideally with lower toxicities. So as I've said, we need to wait for the phase 3 data, something to watch in the future, but whether or not it'll be better is currently uncertain. I'm going to move on to the next trial again in the immunotherapy untreated space. So this is a combination of nivolumab and platinum doublet chemotherapy with relatlimab, which is a LAG-3 inhibitor, compared to nivolumab and platinum doublet chemotherapy alone. So this is the Relativity 104 study. And as we've said, again, LAG-3 is an inhibitory antibody that suppresses the immune system. So very simplistically, relatlimab blocking this receptor will restore effector T cell function. And this trial was a phase 2 randomized study in all comers first line with non-small cell lung cancer. And they were randomized in a 1-to-1 ratio to receive either the combination of nivo chemo and relatlimab versus nivo chemo alone. And there was pre-stratification for by tumor PD-L1 levels greater than 1% versus less than 1%, and also via histology, non-squamous versus squamous. And the primary endpoint here, again, was objective response rates. And if you look here, the groups were very well matched at baseline characteristics, so no significant differences. But when you look at the primary, the outcome, which was the objective response rate and progression-free survival, you can see here that it was actually a negative study. Despite response rates of 51% and a PFS of 6.7 months, this was not an improvement in the combination arm over the standard arm, which was the nivo and the platinum doublet chemotherapy. However, the investigators go on to look at their pre-stratified subgroups. They look at the PD-L1 positive patients greater than or equal to 1%, and there you can see that there is a definite improvement or benefit in using relatlimab in combination with nivolumab and chemotherapy, but not in the PD-L1 negative group. And actually, there is no difference here statistically between the squamous and non-squamous population. Nonetheless, the investigators go on to look at the non-squamous group of patients, and within that, the ones who are PD-L1 positive. And you can then see that there is a statistically significant improvement in the median progression-free survival of 11.6 months and the response rates in the PD-L1 positive non-squamous group. And defining this a little bit more, splitting them between the 1 to 49% and the greater than 50%, you can see most of that benefit and improvement is driven by the cohort of 1 to 49% PD-L1. Toxicities was not really concerning. There were no additional toxicities in the combination of relatlimab. So the conclusions are this was actually a negative trial as it set out to be in the first-line treatment of all comers, but there was a benefit in the PD-L1 positive population, no difference between histology. And because of that benefit that they've seen, they're now going ahead with the Relativity 1093. It's a randomized phase 3 trial evaluating this combination compared with our standard of care pembrolizumab and platinum doublet chemotherapy in first-line patients with non-squamous histology and with PD-L1 levels of between 1 and 49%. So thoughts on this one? Again, as before, there's a need for efficacious treatments. There is rationale for combining a LAG-3 with a PD-L1 inhibitor. But again, we need to await this phase 3 data to see whether or not it's going to be any better, because our current standard of care, KEYNOTE-189, you've got response rates of 47%, median PFS around 8.8 months. You've got to better that if you want to replace standard of care. I'm sorry, that says Galaxies over there. It should say the Relativity trial, but with response rates currently of 51% and PFS of 6.7 months. I know it's early phase 2 data, but one has to wonder whether or not this is actually in a phase 3 trial going to be better than or even replace the standard of care, whether it'll be another trial that does not meet its endpoints. I think some caution here. I think in identifying subgroups of patients that may benefit from treatments is very important. And pre-planned subgroup analysis allows trials to be powered adequately to detect this sort of treatment effect. The more subgroup analysis we do that are unplanned, the smaller numbers of patients we see in these groups can often lead to very misleading benefits that then don't hold up in larger randomized trials, or indeed may sometimes even be missing a significant association. Going to leave behind the immunotherapy side and now look at the targeted therapy space. And I'm going to start with the EGFR exon 20 insertion mutation space, and looking at a drug called zipalertinib in patients who have previously received amivantamab. So zipalertinib is a novel, irreversible, and selective EGFR exon 20 insertion tyrosine kinase inhibitor. And it was studied in the RESILIENT-1, which is a phase 2 study of patients who have this exon 20 insertion mutation, but had also progressed on or after amivantamab. So when we're looking in the UK at our population of exon 20 insertion patients, we're often using chemotherapy as our first line of treatment. NICE did not recommend amivantamab following platinum-based chemotherapy, whereas other countries can use this. So this is looking at patients who have progressed on or after amivantamab, and they received zipalertinib at a dose of 100 milligrams twice a day. And the primary endpoint here was objective response rates and duration of response. Small numbers of patients, 30 patients, were response evaluable at the time point here. And looking at the demographic data, you've got the patients who received amivantamab only, which was the majority of the group, but you've got a smaller number of patients who received amivantamab and also had received other exon 20 targeting tyrosine kinase inhibitors. So these would be drugs such as mobocertinib and poziotinib. We did have the option in the UK to use mobocertinib second line, but unfortunately this was not taken any further and was withdrawn. And most of the patients in these two groups have also received prior chemotherapy. Objective response rate here, as you can see looking at the amivantamab only arm, was 50%, and the disease control rate here was high at 88.9%. At this endpoint, at the cutoff, the duration of response was not evaluable, but the median progression-free survival was a respectable 9.7 months in this pre-treated group. Brain metastases data and CNS efficacy is not as yet available. So treatment-related adverse effects, no surprises here really. We are looking at drugs, side effects that we normally see in the EGFR space, so rash, paronychia, stomatitis, etc. But of course, you also do see some grade 3 toxicities such as pneumonitis and ILD, which do require dose discontinuation. So in conclusion, zipalertinib is a new, irreversible, and selective exon 20 insertion tyrosine kinase inhibitor, which is active in the post-amivantamab or amivantamab refractory setting, with a manageable safety profile, and we awaited CNS data. So this is really a very interesting space now in the exon 20 insertion space. So we had the Chrysalis data, and then more recently the Papillon data, which has shown amivantamab and platinum pemetrexed chemotherapy as being a potential now new standard of care in the first line for patients with the EGFR exon 20 insertion mutation. It has received MHRA approval in July of this year, and we're waiting NICE to give us a decision on this, which is expected probably early next year. And if this does become our new standard of care, amivantamab and chemotherapy, then we would be looking at tyrosine kinase inhibitors such as zipalertinib, which we know are active in the post-amivantamab state, to provide an option for sequencing going forward for our patients. But as Martin had also mentioned in his talk, zipalertinib is not the only drug in this space. You've got cinvosertinib and you've got furmonertinib, also two other TKIs which have shown efficacy in the second line setting, and in small sort of single arm, small first line trials as well, they have shown some efficacy. And now we've got the bigger phase 3s coming along. So you've got the RESILIENT-3, you've got Wukong 28S and the Fervent trials, and these are looking at these TKIs in first line treatment, either in combination with chemotherapy versus chemotherapy alone, which is zipalertinib, or just looking at the TKI itself versus chemotherapy, which are the other two agents. So I think this is a really exciting space for us. I think standard of care is going to change here. And what we'll be looking at is how we go forward. So are we going to need chemotherapy for all our patients in the first line setting? will some of the trials, when they report, allow us to use tyrosine kinase inhibitors without chemotherapy, either alone or in combination with other agents? And as always, what we use in the first line is going to guide our second line choices. So if you use chemotherapy first line, you might not use it straight away. If you use a TKI, chemo will remain an option. But more importantly, we're going to start to look at or understand the resistance mutations and patterns to know what treatments are best going forward. Because what we do know is the resistance mutations you see after second and subsequent line treatments with an agent are not necessarily the same as you will see after first line use. I'm now going to move on to the ROS1 space, and a really exciting drug here, NVL-520. If any of you listen to the BTOG Does ROS1 podcast, we ended by talking about NVL-520 and waiting for the first in human phase 1/2 data on this drug, an exciting drug because of probably its improved safety profile, because it does not inhibit TRAC, so no TRAC-related CNS toxicity. It now has a name, zidesamtinib. They're getting harder and harder to pronounce. And what ARROS-1 is, it's the first in human global phase 1 and 2 clinical trial of zidesamtinib in ROS1 positive cancers. We know that it targets ROS1 mutant activity as well. And one of the biggest mutations is the G2032R solvent front mutations, which has been a problem to target. It develops on crizotinib and on entrectinib, are currently available drugs which are not very effective on this mutation. And so this has been something that is always in the mind to try and target. The recommended phase 2 dose is 100 milligrams once a day, which was taken forward. And if we look at the patient population, this was a heavily pretreated population of ROS1 patients. So 69% of patients had received 2 or more TKIs. Mostly these were crizotinib and entrectinib, but where available, some patients had also received lorlatinib and repotrectinib as well. And the majority, so 66% of patients, had also had prior chemotherapy. In terms of preliminary activity, what you're seeing in patients, if you look on the left-hand side, if they'd received any number of previous TKIs between 1 and 4, you're looking at response rates of around 44%. But if you look at the patients who hadn't received repotrectinib, but the ones who had the ROS1 G2032R resistance mutation, you can see good response rates of 72% in this group, which is very encouraging. If you look at the patients who'd received 2 prior ROS1 tyrosine kinase inhibitors, 41% there again. In the UK, we tend to use either crizotinib or entrectinib based on patient characteristics or personal physician choice. And if you look at the column on the far right there, that is response rates after single agent crizotinib, again, very high at 73%. So deep responses and good responses even in the resistance mutation scenario. These are durable, as we've said. So if you look at the disease control rate at 12 months, 67% of patients are having ongoing responses. And CNS activity is seen with this drug. So intracranial response rates are 50%, small numbers of patients, but these can be patients responding even after they've been previously exposed to a brain penetrant ROS1 TKI, such as repotrectinib or lorlatinib. And here's the safety data. Very encouragingly, we are not seeing the CNS TRAC-related neurotoxicities that can be so troublesome in our patients. So we're not seeing things like the dizziness and paresthesia. And you can see here that there were no treatment-related adverse events that led to discontinuation of the drug, and dose reductions due to adverse events was low at 8%. So that compares very favorably with drugs like entrectinib and repotrectinib, where you're seeing sometimes dose reductions upwards of 30% in this patient group. So thoughts and conclusions: durable response rates, improved safety profile, intracranial responses are seen. So thoughts on this: definitely an excellent drug, and I think something that we should be watching out for, because we're seeing very good responses in our mutant patients and that improved side effect profile. The question will be, where does this drug fit into our pathway? It looks like it might be a second-line drug for us. If you use first-line entrectinib or crizotinib, this would be something that would show response, so it can be sequenced. But of course, with that safety profile being so good and with the really good responses we're seeing in the heavily pre-treated group, could this drug actually replace standard of care in the first-line setting? So I think while imminently we're still waiting for data, and I think the company expects some more pivotal data to come out in 2025, I think this is definitely a drug to look out for in the ROS1 space. And very lastly, I'm going to look at another nuvalent compound, NVL-655. and this is in ALK-positive tumors. Another very exciting drug, because this drug has been very rationally designed. So it's a new generation, a new fourth generation ALK inhibitor, and it's been designed to overcome the problems or the challenges we're seeing now within our ALK pathway. So we currently for ALK produce a second generation inhibitor such as alectinib or brigatinib, followed on by lorlatinib upon progression. And what we're seeing is following lorlatinib, we are seeing mutations that are developing that are often compound mutations, sometimes single agent as well. So this drug has been designed with potent activity against the single and the compound ALK mutations, including the ones we see with lorlatinib, and also the G1202R, which is very similar to the last one in the ROS1, the solvent front mutation, which is quite difficult to target. It's also CNS penetrating, and it avoids TRK inhibition. So again, more selective ALK inhibitor. So in this study, this was again a heavily pretreated population of ALK-positive patients. You can see 50% had had 3 or more ALK TKIs, 58% had also had chemotherapy. Majority, 94%, had been exposed to a second generation inhibitor, so alectinib or brigatinib, and 85% of patients had had lorlatinib. So would be quite representative of patient group we might see in our clinics having had a second and a third generation inhibitor. And you're seeing preliminary activity here. So this is looking at the second line down, which is patients treated at the recommended phase 2 dose in the trial. And with any ALK mutation, you're seeing response rates of around 55%. And with the G1202 resistance mutation, 71%. And if you then look at the middle group, which is the ones we are interested in here, who have had the prior lorlatinib treatment, so patients progressing on lorlatinib, you're seeing again response rates of around 50%. And with those lorlatinib-resistant compound mutations, you're seeing response rates of around 64%. So very encouraging data here. Durable tumor responses with 100% of patients continuing to have disease control at the 6-month mark there, which they looked at. And CNS activity also seen, 50% in the lorlatinib naive group and 15% if they had previously had the brain-penetrating lorlatinib. So CNS active as we expected. Favorable safety profile, again, TRK sparing, so you're not seeing those TRK-related toxicities, dizziness, paresthesia. Dose reductions, 15% due to treatment-related adverse effects, but low discontinuation rate at 2%. So again, perhaps a slightly improved safety profile compared with lorlatinib. So conclusions here. This is a new, exciting, rationally designed 4th-generation ALK inhibitor, which is active in pre-treated patients, including those who have lorlatinib resistance mutation with a tolerable safety profile and intracranial activity. So thoughts on this? Naturally, one would assume this is a good option for sequencing post our 2nd and 3rd generation TKIs, including lorlatinib, because it targets the resistance mutations seen. But we have to think about what is currently our standard of care in first-line use in the ALK-positive patients, because we've now seen the CROWN data, which was presented at ASCO this year, looking at this amazing progression-free survival data at 5 years in patients treated first-line with lorlatinib, where the median was not reached. And so it is very probable, it's very likely that this is going to be a new standard of care in this group of patients. So we will then be looking at what comes next in the sequence if we're going to use lorlatinib first line. And this may be one of those agents that we can use, but also what resistance mutations are we going to see and whether this will be useful. So I think there is definitely going to be a role for this drug, probably earlier in the treatment pathway. And there is plans to initiate a phase 3 early next year in the ALCAZAR trial. Compared with standard of care alectinib, one has to wonder whether that is going to be a true standard of care going forward in this group of patients. So I'm going to end there, and thank you very much for listening.
Meenali, thank you so much. That was an absolute tour de force and incredibly clear. And I thought your thought slides were particularly helpful. There is a lot going on. There are the fascinating slew of these new drugs which are early in their development from the point of view of the audience. You're not going to have them in clinic tomorrow. They do have huge impacts on what happens. We've got co-stimulatory targeting immunotherapies. We've got, we hope, the next generation ROS and ALK drugs, and these really will impact on us. Brilliant. So we're going to move on to Yvonne. Yvonne, you've been a fantastic supporter of the BTOG webinars for many years, and we're enormously grateful for you to help us out with the second bit of ESMO. So this is going to be the early and locally advanced disease highlights. And then just remind people, after that, we'll do a Q&A, so send through any questions you might have. Yvonne, the floor is yours.
Thanks, Tom. It's always a pleasure to be back talking about one of the international meetings. And although it is a challenge to bring the slides together, it's a good opportunity for us to think about how we are going to use the information that we've heard at the conference in our clinical practice. So those are my disclosures. So over the next 20 minutes or so, we're going to stick mainly with early and locally advanced disease. We're going to talk about a couple of molecularly driven cancers in the ALINA and the LAURA studies. We've heard data from these studies before, but we're going to do some fresh updates on biomarker analysis and CNS and distant metastasis data. We're then going to put a toe in the water of immunotherapy and look at durvalumab in the perioperative and adjuvant setting in non-small cell lung cancer and review some of the data from small cell lung cancer consolidation with durva in PCI and related to particular chemoradiotherapy regimens. We'll then look at a very interesting randomized phase 2 study of inhaled corticosteroids and radical radiotherapy. And then at the end, if I have time, I'm going to do a slightly naughty thing, which is go back to metastatic disease, because there was a really fascinating study looking at low-dose pembrolizumab, which potentially has a lot of implications for clinical practice, not just in early and locally advanced disease, but across the board, and also has an impact on some of the studies that we have recruiting at the moment in the UK. So starting off with ALINA, of course, we've seen this practice-changing trial being reported before. So just to remind you, this was patients with completely resected stage 1B to 3 non-small cell lung cancer with ALK alterations, and patients in this study were randomized in a one-to-one fashion to either receive alectinib for 2 years or platinum-based chemotherapy. And you can see from those survival curves of disease-free survival that the primary endpoint was well and truly met with a hazard ratio of 0.24 in the stage 1B to 3A disease, which was consistent with that in the 2 and 3 disease, and a study which resulted in approval of alectinib in this setting, although, of course, we haven't quite got access to alectinib as yet in the NHS. But at ESMO, we saw an update on the biomarker analysis. So importantly, the biomarker evaluable population in this study was very similar to the trial population. It was about 2/3 of the whole population where we had biomarker information available. And it was an off-the-shelf test with Foundation 1 CDX assay. And you can see in terms of the EML4 ALK variants, the most common ones are variant 1 and variant 3, as is consistent with the information that we have from advanced disease, so similar proportions of variants. But importantly, there was no difference in outcome according to the type of variant. So you can see in those survival curves, the benefit of alectinib maintained in terms of disease-free survival, regardless of the variant. In terms of the co-mutations, a number of co-mutations were explored, and in particular, if I draw your attention to the TP53, 24% of patients having co-mutation in TP53, which was slightly lower than the numbers that we saw in ALEX. So TP53 perhaps being less prevalent in this earlier population compared to those with metastatic disease. And what that means in terms of outcome, so you can see on these survival curves that for patients receiving chemotherapy, the co-mutation of TP53 didn't seem to have any impact. But for patients receiving alectinib, those with TP53 mutations seem to do less well. So perhaps some considerations for the future there, but what I would point out is there's only 20 patients in that arm, so only 20 patients with co-TP53 mutation. So I think it's a little bit early for us to have this impact on our clinical decision making as yet. But of course, we have seen TP53 mutations in other types of oncogenic drivers having an impact on prognosis. So I think this is an area for us to watch, but probably too soon for it to have any impact on our clinical practice just yet. So moving on to EGFR, you've heard from Tom and from Martin earlier today about aumolertinib in locally advanced disease. So this was data from the LAURA study, which was looking at osimertinib in locally advanced disease, and particularly the focus of the ESMO presentation was on CNS disease and distant progression. So just to remind you, we've seen Laura presented before. So this is patients with stage 3 locally advanced unresectable disease with one of the EGFR common sensitizing mutations being randomized after chemoradiotherapy to either receive osimertinib until disease progression or placebo, and that was in a 2-to-1 fashion. Important to note in this study, the imaging of both chest and brain was carried out throughout the study. And you can see, we've seen before the data from the LAURA study, which was so impressive from that progression-free survival curve with a hazard ratio of 0.16. And this data really has already changed clinical practice in much of the world, although not in the UK as yet. We're still awaiting the NICE decision on this. But you can see not only were those curves so widely split, but also in the patients receiving the placebo arm, how poor those patients with stage 3 EGFR mutated disease fared, with only 13% of them at 2 years not having progressed. So really behaving much more like stage 4 disease than stage 3. So to look at the particular areas of interest following that initial presentation, there were questions about the staging of these patients. So there were questions about not all of them had been staged by CT PET, and so were there some differences in those survival curves that were driven by differences in staging? So this presentation showed on the left-hand side at the top patients who had a PET scan versus those on the right-hand side who had not had a PET scan. About 55% of them had a PET scan, and you can see that regardless or not of whether they'd had PET staging, those benefits for osimertinib were maintained according to whether or not they'd had a PET scan. Then going on to look at distant disease, at the bottom left-hand graph you can see there, that is looking at the cumulative instance of distant metastases. The dotted line is distant metastases, and the more dashed line is those with local recurrence. And so you can see again patients receiving osimertinib having a much better outcome, both in terms of distant and local progression. And then the very lowest graph on there is the survival curve. So actually you can interestingly see that all of these patients, when they did develop disease progression, went on to osimertinib, and the outcomes on osimertinib are excellent, with those really very flat survival lines at the bottom. Then when you go on to look at CNS progression, similar to what we've seen in patients with advanced disease, and indeed in the ADORA study of adjuvant treatment, we can see that the osimertinib is neuroprotective, with those big differences and improvements in CNS progression-free survival for the patients receiving osimertinib. So what does this mean for us? Well, the benefits of osimertinib following chemoradiotherapy were consistent whether or not there was PET staging or not. There's a really big difference in the rate of disease progression distantly at 12 months, 11% on patients receiving osimertinib compared to 37% for those on placebo. The CNS effects we've touched on, 9% on the osimertinib arm at 12 months compared to 36% for those receiving placebo, with a hazard ratio of 0.21 for time to distant metastasis or death. So this means that there's a really clear sign of CNS progression, with a hazard ratio for CNS protection for PFS at 0.17. So my thoughts on this is that there's a very clear benefit in this setting for osimertinib, and this will be practice changing for us when we eventually have access to treatment, as some of the other areas of the world already have. There are some questions. So, of course, in ADORA for adjuvant osimertinib in the post-operative setting, we have osimertinib for 3 years. In LAURA, post chemoradiotherapy, the treatment is continuous. When we think about the disease-free survival curves in the DORA, there was a suggestion that they might be coming together after 3 years when the treatment stopped. But of course, in LAURA, the patients are continuing on osimertinib. So there's always a question about how much treatment is enough, and I'm not sure we entirely know the answer to that yet. But the treatment in this study was until progression. Okay, so moving from molecularly targeted therapies on to immunotherapy. So the Aegean study, we have seen data from this presented previously last year. So just to remind you, the Aegean study was a phase 3 randomized controlled trial looking at perioperative durvalumab. So patients with resected stage 2 to stage 3B disease, so no stage 1Bs in this trial, who were planned to have a lobectomy or bilobectomy, and no EGFR ALK alterations. And they were randomized in a 1-to-1 fashion to either receive durva plus chemo for 4 cycles or placebo plus chemo neoadjuvantly, and then a year of durva or placebo in the adjuvant space. And just to remind you, in this study, we're looking at the ctDNA clearance during that perioperative period. And you can see the timings of those samples highlighted in the blue dots in the middle arrow. We've seen the outcome from this study previously reported with a hazard ratio of 0.68, and there's very clear splitting of the survival curves as we've seen in many of the perioperative and neoadjuvant studies, and with the pathological complete response and major pathological response is very consistent with the other studies. So just to remind you, circulating DNA is emerging in non-small cell lung cancer as a very important biomarker. There are various ways of doing this. There are some off-the-shelf ctDNA ways of assessing minimal disease and disease recurrence. But in this setting, there was a tumor-informed, personalized approach, which meant that there had to be specific tissue available for the patients to then have their ctDNA followed up. And the reason that this is so important is because following up ctDNA may then allow us to intervene and to either escalate or de-escalate therapy at a later date. So this is a slightly busy slide, but if you look on that first table on the left-hand side, this is looking specifically at the patients who had ctDNA clearance. So at the beginning of cycle 2, so after the first cycle, if you look on the first line on the table there, the positive predictive value of having ctDNA clearance was 49% for the patient to then have a pathological complete response. And I suppose on the other end of the spectrum, you can see that for patients prior to surgery, at the bottom right-hand corner of that table, if they had not cleared their ctDNA, there was 100% negative predictive value for a pathological complete response. And if you look in the chemotherapy arm, those positive predictive values are much lower. So for patients receiving chemotherapy, only 11% positive predictive value for clearance. And then if you look at the bottom right-hand survival curve, this is looking at patients who had ctDNA present at that first point in the adjuvant setting. So for those patients on the at the first point post-surgery, if they still had ctDNA present, you can see that that survival curve is absolutely terrible, with essentially all of those patients having relapsed and recurred at about a year. So some indications here that ctDNA in that post-operative setting may be able to identify patients that are going to do extremely badly. So how does this help us? Well, it's not ready for the clinic yet. This was personalized ctDNA, and actually in the trial itself, there was a high attrition rate, and only about 50% of the patients actually had a valid test that could be followed up. So we're not quite there in terms of being able to use it in the clinic next week. However, it does give us some information about perhaps the major questions that we have in the area of perioperative treatment. So we heard some information from Martin earlier on about perhaps those patients who have a pathological complete response not necessarily being those that are going to get a benefit from adjuvant immunotherapy. And we've seen that in a number of studies. But perhaps this study gives us some pause for thought about patients who still have ctDNA present post-operatively. Now, it's not a big group of patients, only about 5% of the population here. But for me, this means that those patients are not going to benefit from an immunotherapy of the same sort in the adjuvant setting. And actually, we really do need other options for that group of patients. So sticking with Durva, this is a negative study, but really important for us to consider. So this is BR31, which was the adjuvant study of durvalumab. So patients with stage 1B to 3A disease, EGFR and ALK aberrations were allowed, but we will look at those excluded from the data set. And they were randomized to either receive Durva or placebo for a year in a 2-to-1 fashion, with disease-free survival in the PD-L1 greater than 25% cohort, EGFR and ALK negative being the primary endpoint. And you can see that this study is negative in the primary endpoint, and also negative in the populations of PD-L1 greater than 1% and in all comers. So disappointing results. It wasn't particularly related to any difference in toxicity in patients stopping treatment. You can see the discontinuation rates for durvalumab there, about 14%, so consistent with the studies that we've seen with other drugs in this setting. And I think what this does underline for me in my clinical practice is that we have seen probably less strong signal for adjuvant immunotherapy compared to the neoadjuvant and perioperative studies. And it probably underlines to me the importance of the neoadjuvant component in the perioperative setting. So sticking with Durva for a moment, but moving disease sites from non-small cell lung cancer to limited stage small cell lung cancer, we're going to look at the Adriatic study, which is the phase 3 study in limited stage small cell lung cancer of patients with concurrent chemoradiotherapy being randomized to either receive durvalumab or placebo following initial treatment. The Durva Tremi arm has not yet been reported, so it's just the Durva and placebo that we're going to be looking at. And in particular, we've seen this data before, but in particular, we're going to be looking at the different types of chemoradiotherapy regimens and the use of PCI. So in the top two survival curves, you can see for patients that either had PCI on the left or those that didn't have PCI, and you can see that that improvement with Durva compared to placebo is maintained regardless of the PCI treatment or not. In terms of the chemoradiotherapy regimens, they looked at carboplatin versus cisplatin, and you can see perhaps a numerically greater benefit for patients receiving carboplatin compared to those on the cisplatin with durvalumab, but the benefit's still there and consistent. And at the bottom, when we look at the twice daily versus once daily radiotherapy, again, on the twice daily radiotherapy, you can see that those outcomes are probably a little bit better in terms of overall survival compared to the once daily, but again, that consistent benefit with durvalumab. And it's really important to note the tail of these curves. And if you look across the board, there's about a 10% improvement in those difference between those curves on the tail. So really establishing that benefit of durvalumab in the post-chemoradiotherapy setting for limited stage small cell lung cancer, regardless of the chemoradiotherapy regimen or PCI. And of course, this has changed practice in other parts of the world, but not quite yet in England, and we're still awaiting NICE's view on this. But for me, if I had access to this regimen tomorrow, it's something that I would be wanting to use in my limited stage small cell patients. So changing tack again, moving from some of our exciting new treatments to a rather old-fashioned treatment. So inhaled corticosteroids in patients receiving radical radiotherapy for locally advanced non-small cell lung cancer. So a great study, a single center study, phase 2, and they've recruited nearly 300 patients to this study. So patients with stage 3A or 3B unresectable disease. And they were randomized to essentially either have twice daily inhaled steroids or not, to look at the incidence of pneumonitis, radiation-induced pneumonitis, with secondary endpoints, as you can see on the slide. So in terms of the patient characteristics on the left-hand side, I would just point out to you that there were perhaps older patients in the group who received corticosteroids inhaled. So you can see 46% greater than 65 years compared to only 33% in the control arm, and perhaps more adenocarcinoma histology in the corticosteroid group compared to the control group. But when we come to look at the instance of radiation pneumonitis, you can see that patients who received corticosteroids had a significant reduction in the instance of radiation pneumonitis compared to those that didn't. And in particular, the rates of grade 3 radiation pneumonitis were substantially reduced. Now, when you look at those figures there, I've been thinking about them quite carefully, because when we've discussed this following the meeting, there was a number of comments about the rates of grade 3 pneumonitis seem to be very high at 53 versus 34%. But when you look at the data, it's the way that they've presented this data, and it's actually 28% in the standard arm versus 12% in those receiving steroids, but still a very substantial reduction in the rates of pneumonitis with no statistically significant difference in the survival. So although this is a randomized phase 2 study, that's a really impressive reduction in the rate of grade 2 pneumonitis. It's very easy to put into practice and very low risk. So, you know, I would really ask why we aren't all doing this tomorrow, even although it's a randomized phase 2 study. So finally, I wanted to touch on this study, even although it's metastatic disease, because it's so important for a clinical practice. So it's looking at low dose versus standard dose pembrolizumab in the treatment of advanced non-small cell lung cancer. And this was the interim results of the ENVOLT-30, or the Dedication 1 study. So just to remind you, in terms of dosing of immunotherapy for patients with advanced disease, KEYNOTE-010 did have 2 doses of pembro that were dosed per body weight. In terms of what we know using clinical practice, we use a flat dose, neither of those 2 doses, which were fairly similar. And of course, there's not really the same dose response with immunotherapy as there are with other anti-cancer agents. So we have this situation where we have flat dosing for most of immunotherapy agents, but is that right? Is it too much? Is it enough? You know, are there ways of us delivering the same benefits of immunotherapy with less treatment, less frequently, or less by way of dose? So the Dedication 1 trial randomized patients upfront who were suitable for immunotherapy. So that was either single agent pembro or pembro chemo. And they were randomized to either have standard dose chemo or to have reduced dose, which they assigned to be either 300 milligrams 6 weekly or 100 milligrams 3 weekly. And the primary objective was to look for non-inferiority of the low dose arm. Very importantly, at the interim analysis, they were looking for a difference of 10% or more in the 1-year survival to see whether that was clinically, and they regarded that, if they saw a difference of 10%, that would be clinically relevant, and they would stop the trial at that point. However, what we can see is that actually there's no significant difference in either overall survival or progression-free survival at the interim analysis. There's only a 2% difference in 1-year survival, 55% compared to 57%, and similarly only a 2% difference in progression-free survival. And you can see from the baseline characteristics, they were fairly consistent. And when we compare this information to the data from KEYNOTE-189, actually, you know, this is a relatively real-world population. So 1-year overall survival, 58% compared to 70%, median overall survival, 17 months compared to 22 months. So really quite encouraging data. And I think it has really important potential consequences for us in terms of the cost of delivering immunotherapy, if this then translates into clinical practice in a variety of different settings. Potentially capacity if we're looking at other regimens with less frequent dosing, but also trial recruitment. And I just thought I'd finish on this slide looking at our own UK study, which is a slightly more complicated study looking at patients after their initial 6 months of immunotherapy, providing they're stable, and then looking to compare 6-weekly treatment with 12-weekly treatment. And if 12-weekly treatment is not detrimental, then looking at some de-escalation on that 12-weekly treatment. So I really look forward to us continuing to recruit to the REFINE trial. And the reason for mentioning envelope 30 is because I think this gives you a real good opportunity to be able to assure patients that are getting into the REFINE trial that we've already seen some data suggesting that more is not definitely better, and actually de-escalating may be a good thing to do. And there are some other studies going on in Europe in a similar vein. So with that, in terms of how I've sort of summed up the trials that we've talked about, so the biomarker analysis for Alina, it's interesting, but not ready to change our practice yet. The LAURA study, obviously, we would be changing our practice, and there's now some increased information available about the effectiveness in both in CNS and distant metastases. The AEGEAN study has given us some information about biomarkers and perhaps thinking in the future about how we consider which patients should be suitable for adjuvant therapy. Some disappointing data from BR31 to do with adjuvant durvalumab, but that feeding into the choices that we make in our clinical practice and every day about, perhaps if we've got patients that have got high levels of PD-L1, we have the option of perioperative neoadjuvant treatment or adjuvant treatment. But actually, for me, the neoadjuvant component is becoming increasingly important. The role of durvalumab consolidation in small cell lung cancer. So again, practice changing when we have access to it. And inhaled steroids and radical radiotherapy. Now, it's only a randomized phase 2, but as I said, it's pretty straightforward to introduce into a clinical practice. And the final thoughts about the low-dose pembro. So I will stop there.
Yvonne, thank you very much. I'm loving your star ratings. I think that's excellent. Brilliant. Thank you very much for going through all of that. I'm going to ask my panel to put their cameras back on. I've got some questions on the right here and some questions in front of me. I'm going to ask Martin first. Martin, one of the first studies you talked about was a comparison between 77T and 816, checkmate 77T and 816. Trying to work out the answer of, is neoadjuvant enough, or is there any benefit in adding adjuvant immunotherapy after neoadjuvant chemoimmunotherapy? The trouble being that we're never going to have a randomized study, at least no time soon. In fact, probably never. You did touch upon this, but what were your kind of thoughts on the validity of that study? Because there was some criticism in the room that you're not really comparing the same group. The 816 patients only got neoadjuvant treatment. The guys who got 77T, and you're looking at the ones who had some adjuvant treatment, have got through surgery. They're quite well. You're thinking about giving them adjuvant treatment, so they're not really comparable. Do you think that detracts from the result? Or have you come out of that saying, do you know what? If I had access to it for my non-PCR patients and my PD-L1 negative patients, I would be giving an adjuvant immunotherapy if I could. That was to you, Martin. Oh, maybe Martin can't hear me. Martin, can you hear us?
How we might.
I think we've got a slight problem with Martin's line. So what I'm going to do is I'm just going to skip over and I'm going to ask Meenali something while Martin gets his connection sorted out, because either that or he's doing a very good impression of someone who's not moving. Meenali, so Galaxy's 201, TIGIT, very exciting. We had some data on LAG-3. We've been looking at TIGIT and LAG-3 as things which maybe haven't worked so much so far. Were you convinced by Galaxy 201? Is this actually an active drug, or do you think this is at risk of being a phase 2 data, which actually, when it comes to phase 3, boils away and becoming nothing? What do you think?
Honestly, Tom, at the moment, the feeling is that both of these phase 3s are probably not going to come to a huge amount. I think probably they aren't going to push away our current standard of care or exceed them in any way. It might not be that the drug itself is not useful. I think perhaps we just need to know a little bit more about the mechanism of action of the drugs and the combinations and the patient groups that we need to choose in a rational way who may or may not benefit. But to do these sort of big studies just using these inhibitors in a big group, I think we risk a negative trial. So I think I'm not optimistic that these phase 3s are going to change our current practice. I'm worried they might go the way of other phase 3s at the moment.
And there's some other approaches targeting TIGIT, some bispecific antibodies, PDL1 on one arm of the antibody, TIGIT on the other. Do you think these novel approaches to targeting co-stimulatory molecules like TIGIT have legs, or do you think we're just going to end up with unpronounceable drugs with no significant augmentation of efficacy?
I think it's really difficult, Tom, because we've had a lot of these molecules in the second line setting that haven't really had a huge impact yet in terms of showing good response rates and durable response rates, perhaps more in the oncogene addicted arena than in all comers as well. So I think we're looking at the data now in the first line setting. I don't know whether or not this is the right way forward, is the honest truth with these molecules. I think, again, it's all about we need to just understand the pathway and the environment a little bit more with our immune responses and target these drugs a little bit better.
That's very interesting. But we've got some studies open at Chelsea. I'm sure you've got similar ones looking at some bispecifics, which are very interesting. Martin, I think you probably heard my question, but we lost you on the reply. If you wouldn't mind replying to your thoughts on that 770-816 analysis. Thank you.
Yeah, thanks, Tom. Sorry about that. I'm cutting out a little bit. I was just saying I think it's interesting data. I agree that I don't think it's definitive. I think it's interesting without stealing her thunder. Obviously, Yvonne also talks about the ctDNA clearance, so I think there's a number of tools. I think it seems fairly clear to me that those patients who don't get a path CR are going to need something more. And the question is, what is that more? I think it's interesting seeing the pembrolizumab data perioperatively and showing overall survival benefit for the first time, compared to these other neoadjuvant approaches that may or may not turn out to be differentiating. Certainly ctDNA clearance, I think there's a number of biomarkers we might want to do. So I think that there will be some mileage in adjuvant, post-neoadjuvant. I don't think we quite know how to select those patients yet.
Gotcha. No, I think that's a fair comment. From a question from the floor for you regarding the inhaled steroids. A lot of patients receiving chemo-rad have COPD and are already on inhaled steroids. Were they excluded from the study? What a great question.
Yeah, so I don't know the answer to that. I don't remember them actually saying, making that clear in the presentation. You would imagine the answer to that would be that they were excluded from the study, but I don't know. And the other thing I would say that is, in terms of how you introduce that into your clinical practice, I'm not sure it makes a difference, does it? This is a very practical study. So, make sure that if your patients are on an inhaled steroid, that they're using it. Do they just carry the inhaler and actually never use it? Because many of mine do exactly that. So check if they're using it and suggest that they do.
Yeah, absolutely. Now I'm going to go back to you and the zipalertinib data. Just to remind people, that's the agent targeting in this data set the EGFR exon 20 insertion patients. As you rightly said, we're hoping that we will get a chemo amivantamab combination available in the NHS. Perhaps in the spring, if that gets through. Nice. We don't have access to AMI second line post chemo. What's your take generally on the TKIs and their activity, and their adverse events compared to the adverse events that we're seeing with amivantamab? Do you think these are going to be an easier prospect? Do you have experience of amivantamab? Is that a drug which you find is easy to manage?
So not a lot of experience with amivantamab, but I know from people who have used amivantamab that it's a really tricky drug sometimes to manage in terms of the toxicity profile we're seeing. So I think we're all very familiar with managing the TKI toxicities we see with osimertinib, for example, and the other agents. But with amivantamab, I believe the paronychia and the cutaneous skin reactions are quite dramatic and quite a lot worse. And also there's the infusion reactions and the edema, which has also been quite problematic with amivantamab. So whilst it's more efficacious, I think the toxicity profile is harder probably to manage than the traditional TKIs that we've been using. And I think when you get drugs that are probably equally efficacious or there's not a lot in it, I think these sorts of toxicity data will become increasingly important, as also will be the infusion schedules and things, because amivantamab, again, there is not straightforward. You have to have maybe a split dose, weekly dosing for the first 4 weeks, etc., before it goes 3 weekly. So I think these are all very real considerations when using something like amivantamab.
Thank you very much. We should probably give a shout out to, there's a study called the Skipper study, I think, which was looking at prophylactic steroids before amivantamab to reduce the infusion reactions. It does significantly, interestingly, although it doesn't reduce the other cutaneous mucocutaneous tox, which I agree are probably the Achilles heel of amivantamab. Martin, Harmony 2. So I'm going to play the positive role. I'm going to say it's an amazing study. I'm going to say this is the first drug that has been properly better than pembrolizumab in first-line treatment of lung cancer. You have a hazard ratio of 0.51. That's absolutely incredible. It was in PD-L1 weak positives and strongly positives and squamous and non-squamous. This is amazing. Is my enthusiasm poorly placed? Just to remind people, Harmony 2 was the bispecific antibody ivonescimab, which hits PD-1 and VEGF. Am I being naive? Or are we being derogatory about studies only undertaken in China when actually we should look at that data equally fairly? Or do you think actually when this is expanded broader across the world, we might see a drop in the efficacy of that agent?
Yeah, again, another good question, Tom. Perhaps not surprising. I think so. I would look at the data at face value and say it does look very promising. I would agree with you. I think it looks very interesting. Having said that, I think we do have to be cautious. We've seen sort of ratio. So I guess there's different things. I don't think there's any reason to think that the studies are delivered any less effectively. They're following trial criteria like we would. But we know there are racial differences. Of course, we've seen that in the oncogenic-driven cancers in particular, but we've also seen now quite a few studies in China with small cell and other cancers, which, for example, the small cell with a very low, much higher than we see, a non-smoking population. So there's different biologies, I think, perhaps in part, which are maybe difficult to decide why, but so having a single country study, which is very racially distinct, I think has got risks associated with it as to how transferable that is to the UK. So I don't think that we should sort of belittle the data. The data are good, but I do think we would want to look at it in more detail in a global study to confirm that promising early first set of data.
Yeah, I think that's a very fair reply. Yvonne, you've made lots of interesting ones. So just to say to people that adjuvant alectinib is currently going through NICE, and we would hope to have the outcome of that NICE decision in the imminent future. So let's keep our fingers crossed that is something we can offer our patients. One thing that really struck me, I actually missed the presentation at ESMO because I had to go back and do some work on Monday morning. But that was the LAURA data. And the LAURA, as people remember, is osimertinib for locally advanced disease. And one of the criticisms of the data when it was presented in ASCO was they didn't tell us how many people had PET scans, and you touched on this. And there was a criticism that one reason why people were doing so badly in the control arm, people who got chemo and didn't get the osimertinib, was because actually it weren't properly staged. And if you properly staged them, you'd realize that you would have excluded the people doing badly who actually had micrometastatic disease. But actually, I was really surprised that the PET data showed that whether you had a PET or not, there was no difference in the additional benefit of LAURA. Were you surprised by that? Was I being a bit dumb thinking there was going to be a difference? And how does that PET data allow you to see the role of osimertinib in that locally advanced patient setting now?
So, I mean, I guess I agree with you. It's perhaps surprising that there was no difference whatsoever. But I guess sometimes with our patients, particularly with EGFR mutated cancers, I mean, we quite often see these being treated as when they've got multifocal disease as sort of multiple primaries, and actually it ends up that they've got all of the areas that were ground glass and had some sort of solid components to them, they all end up being EGFR mutated cancer in the end. So perhaps not so surprising, because maybe a lot of these cancers are essentially stage 4 but not lighting up on the PET scan. And I think most of our oncogenic driven cancer, it does tend to be a more systemic disease, as we see by the higher rates of CNS disease. So I mean, I think it's really important that we're essentially now getting to the point where we're treating these patients with their molecularly targeted therapies from an earlier stage. And I guess with the LAURA data, the continuing of that adjuvant osimertinib long term probably is something that is more comfortable from a clinician's perspective and a patient's perspective, providing they're tolerating it well.
I agree with you completely. I think we got out of time. I would like to just give a bit of bigging up some future events in BTOG. So we got our mesothelioma essential update coming the 9th of December. This was an incredibly successful meeting 2 years ago, organised by Riaz Shah, big friend of BTOG, and it was one of the most popular meetings we've done for a very long time. So do come along. I'm sure it's going to be equally excellent. It's the Cavendish Centre in central London, and we're delighted to do that jointly with our friends and colleagues at Mesothelioma UK. Hot on the heels, but in the new year, end of January. Now, normally end of January would be BTOG time, right? But as you know, BTOG annual meeting is now in the spring. But instead, we've got a therapeutic strategies for stage 4, a meeting I'm involved in organising. This is again at the Cavendish Conference Centre, 31st of January. It's a Friday, very much focusing on stage 4 disease in the targeted therapies and the immunotherapies, something which is such a huge area, expanding so quickly that we felt, and there's such popular demand for this, we felt an individual meeting was required. So have a look at the website and you can find out more details. And of course, the main event is Monday the 3rd to Wednesday the 5th of March. Yes, it's a Monday to Wednesday. It's extremely confusing for anyone who is a BTOG regular. It's not the Wednesday to Friday. But that's where it's going to be, and it's going to be fantastic. Abstracts are open till the 9th of December, which reminds me I've got to get that sorted out. And as ever, more details are on the website. So I'm going to thank our excellent panel. I can't tell you how hard work it is to do this. Yvonne, Martin and Meenali, thank you very much. I would like to say to people online, I've got a message from Dawn saying, when you finish, please press the button that says lesson completed, or words to that effect, because apparently we need that to know that you've logged off. So please do that. We very much hope we will see you at the mesothelioma, the targeted therapies sessions, and if not, we look forward to seeing you at our annual conference just 4 or 5 months away. Thank you very much for joining us tonight. Good night.